Hi, everyone. We're going to give folks a little bit of time to go ahead and join. So come on in, make yourself comfortable, and we'll get started soon. Hey, everyone. Welcome in. We're just getting settled, and then we'll get started shortly. All right. Hello, everyone. Welcome in. We're going to go ahead and get started. And so you should be seeing my face, and you should be seeing the screen. I'm Stella Sappho, and I am happy to be welcoming you into our monthly social medicine rounds. Get yourself comfortable. We have an hour with an incredible speaker, and let's just orient you to what we'll be doing today. So first off, social medicine rounds are part of our tradition at the Department of Family and Social Medicine to really create a space that allows us to talk about the different issues affecting our communities. And these are everything from the biomedical to the economic to the psychosocial concerns that may be affecting our local communities and may have repercussions regionally and nationally. And so if you're interested, you can point your camera to the top upper right-hand corner and take a look at our website where you can see all of the social medicine rounds we've had before. And we are also happy to send in for you the link to be able to get the recordings if any of the topics are of particular interest. We are going to be today speaking with Miss Ayesha Jaco of Westside United, and I'm going to go ahead and introduce her. And so I'm coming off of screen for a moment so I can get to my notes. And Ms. Jaco is someone who we've been working to get for some time. If you're a member of the Social Medicine Rounds Committee, we tried to do an anchor model presentation last year and couldn't quite get our folks together, but we had in mind to really go to the Chicago folks because that's where a lot of this work has come out of, to really meet them and talk with them about what they've done. And so it is a pleasure to get to welcome Ms. Jaco to be with us today. So Ms. Ayesha Jaco is an award-winning nonprofit executive, choreographer, and creative director with a track record of building pioneering social impact brands and convening innovative community-led initiatives. Over the past 20 years, her Chicago-based work has leveraged local community-led initiatives to national platforms, awarding over 20 million in funding and investment to Chicago residents and organizations. Ms. Jaco currently serves as the executive director of Westside United, where she'll be representing today. And under her leadership, Westside United's contributions to racial and health equity efforts in Chicago have been referenced in the Harvard Business Review, and MIT Sloan's Management Review, and the New England Journal of Medicine. Ms. Jaco is a 2021 Leadership Greater Chicago Signature Fellow, and she's the recipient of the Helen and Tim Meyer Charitable Foundation Achievement Award. She serves on the board for Choose Chicago, Rush University Medical Center, and University of Chicago Medicine's Translational Medicine External Advisory Board, as well as Chicago Chronic Condition Equity Network. We are so pleased to get to welcome her today. And as I do so, I want to anchor us in what we'll be discussing with our rounds today. And so specifically for those of you who have heard about this, we'd love to kind of know, because the term anchor rounds anchor model isn't something that many people are familiar with. So we'd love to know, have you ever heard of anchor models in healthcare? Yes, you've heard of it. No, you haven't heard of it. I'm not really sure if I've heard of it, don't really know what it is. And this will just give us a sense of kind of where we're starting as we move forward. Take another couple of seconds to fill that in for us. Okay. Wonderful. So it looks like for those who are here, almost 80% of the folks who are with us today haven't heard of the term anchor models. And so I'm really excited to bring this to y'all because it's an important way to address what we often talk about, which are the social drivers and ultimately the structural drivers that impact individuals' health. And so it is a pleasure to turn it over to Ms. Ayesha Jaco to talk to us about what anchor models are and to tell us about all the work that she's done to bring this to the Chicago area. So Ayesha, I'm turning it over to you.
Great. Good afternoon. Greetings from Chicago. I'm just going to pull up my deck, and I just want to say thank you, Stella and team, for inviting me to this space to talk about our work. I'm going to share out a little bit about Westside United's origin and, yes, to talk about the anchor model space. So, as mentioned, I serve as executive director. I came into this role as the first staff hired initially to help build out the vision of Westside United, which was really around decreasing Chicago's life expectancy gap at the onset between Chicago's Loop and 10 Westside neighborhoods. Those Westside communities, if combined, would be the size of Milwaukee, Miami. So that particular region of Chicago covers and kind of serves as a small city. But in terms of what I bring to the space beyond my bio that you heard is a lived experience in this region, in the community that has the lower life expectancy that we'll talk about. I've had family members experience premature death due to the leading causes and drivers of the life expectancy gap. And so coming into this space, transitioning out of hip hop and philanthropy here in Chicago, doing work, was really inspired by a text that I would encourage all of you to get by one of our champions, Dr. David Ansel. It's called The Death Gap. And it basically lined up, or outlined, I should say, the fact that your zip code determines your quality of life. And I was just like, whoa, I've always known that, but felt like it was the status quo and that it was just the way it was supposed to be. And so the context that he put it in, also speaking to his privilege as a doctor, a white doctor of Jewish background and heritage, but knowing just in terms of the roles that he's played at safety net hospitals, private institutions, that these institutions that are hundreds of years old, in some cases, played a role due to historical disinvestment and structural racism in terms of the current conditions in the communities. So after reading that, I got an opportunity to come into this space, to come back home, if you will, to the West Side to help work in this space. So I want to talk to you about more around the origin of this work. So I mentioned the life expectancy gap. This is a map of life expectancy across the train lines here in Chicago. So if we were here in Chicago and we wanted to activate this conversation, I would put us all on the Green Line train coming from downtown and take us all the way west. And you can tell if you look to the right, the higher life expectancies are those that are closer to downtown. These are also some of the areas that are more gentrified in Chicago. And as you move further back west, to the left, you see that there's a drop in life expectancy. And so this map was born out of Rush University Medical Center and their community health needs assessment in 2016, where this came out for that particular institution. And Rush had a reputation of being excellent and delivering quality, and their reviews across the respective evaluators came out on top. And at the time, you had Dr. David Ansel, who's the chief medical officer, who's also the author of The Death Gap, and his leader, Larry Goodman, who was CEO of the system and the university, come together to think about how the system wanted to be more intentional about addressing this gap, and that they wanted to be more than just excellent in care, but to be responsive of what was happening in these communities, in the backyards of the medical district here, where you have Rush, you have a public safety network, or sorry, public safety, well, not public safety, safety net, thinking about the Department of Public Health and conversations earlier, in this mix, a university health system, a little ways down, a few miles back west, there's another institution, and the west side is their backyard. So Dr. Ansel, Dr. Goodman set a table for them to look internally first within Rush to think about how they could work with their workforce from these zip codes to be more responsive. And so some of that early work was around seeing who they hired in West Side zip codes. They came across data showing that they had people working in entry-level non-clinical roles, retiring in those roles 30 years later, going back to communities on the West Side where they didn't own where they lived. So they wanted to be better. And so in them having an awakening of sorts, they brought other systems in the medical district, and that had a large footprint of patient populations in the West Side. And there were 5 others: Lurie Children's, Cook County Health, which is that safety net I mentioned, UI Health, Ascension, and Sinai Chicago as part of that initial group. So the idea was that if combined, these institutions would be the #1 employer in the state of Illinois. Their investment capital is massive for those that have access to that unrestricted revenue that they can spread around. The number of live births within this collaboration was around 7,000. And so there was some power in this share table. And they began to think about the question, what if? What if out of our numbers of hires, we dedicated out of our workforce of 43,000, a target to hire 4,500 West Side residents? What if out of our spend capability and thinking about how to diversify our supply chains, to think about how we activate the local corridors and economies, we directed $40 million of spend to West Side vendors? What if in corridors that had been decimated during the riots in 1968 when King was assassinated, we thought about supporting small businesses on the ground? So those were questions that this table began to ask. And in that, this map of the West Side of Chicago became the focal point. And on this map, you'll see the 10 communities listed in the bolded blue. You'll see assets here. So the idea was that the West Side has a lot of beauty, a lot of history. How do we leverage what's there by virtue of working with community, by recognizing the heritage in these spaces? And so this was just a marker. And at the top, you see after those initial meetings in 2017 around brainstorming on what could be done, there were a series of community conversations. So within each of these communities, there are anchor organizations that have been on the ground for decades. In some cases, they have what we call here quality of life plans. That is the community's plan for the next decade in terms of workforce, education, housing. So we went to talk to those people to hear from them what they thought were the key drivers in the life expectancy gap. And what some of the solutions were. And so after talking to about 1,000 residents across this region, what came out of those conversations were that people wanted 4 things. And I think there are 4 things that, we might all want in terms of safe neighborhoods, equitable access to care, jobs, and meaningful things for young folks to do in addition to equitable education. It's kind of grouped together. And so from there, we formed the pillars of West Side United. We wanted to focus on neighborhood and the physical environment. So what was food access like? How could we impact through the flexible unrestricted revenue, social impact investing to help with some of the neighborhood aspirations for affordable housing and other capital improvements and investments? In terms of health and healthcare, we're going to talk about some of the health-related drivers, but we decided out of the 5 drivers, to double down on maternal child health and hypertension management across these communities. And so part of that was aligning within systems. So we had these institutions that are historical competitors that have been siloed now coming together to think about what they were implementing in those spaces, particularly when we talk about maternal child health, focusing on African American women who have the highest disparity. And on this map, East Garfield Park is that community in the region. So what were people delivering? What were some of those best practices? How could we coordinate care, standardize care? How could we think about data sharing? How could we think about community-based practice? Or questions that we're still asking, but that came out at the onset. We also wanted to think about economic vitality, again, leveraging the anchor power of the hospitals. So again, that's the ability to hire local, the ability to procure and diversify supply chain, the ability to invest. There's also some work that we do around career pathways to address the cases of having folks work in these institutions for decades and retire in the same positions. We built pipelines that have entry points into medical assistant pathways, certified nursing assistants, respiratory therapists, phlebotomists, dental hygienists, all around a tuition reimbursed framing, or ultimately is free in partnership with a local anchor community college. And then there was education, as we heard directly from community. So we began to track how many internships we were providing to high school students in these areas and what was the pathway. Were those transitioning into pathway opportunities, employment at health systems? So a little bit about the region, the origins, and the initial pillars of our work. And then again, these are our founding hospital partners that came to the table to join Rush and to take this on. And I should also mention, at the onset, we released an anchor mission report that I can share with Stella to be circulated to each of you, that just shows, in partnership with the Healthcare Anchor Network, some of the findings and learnings that came out around some of those initial hiring and investment projects. So I talked about community voice, which is so important in this work. In those initial listening sessions, what we heard from community was create nothing for us without us. Like, we understand some of the nuanced nature of the problems, what they are, and what the solutions can be. We need access to resources. So if you're going to build anything on behalf of the West Side, we need to be at the table in the driver's seat. And so we listened. And so that initial work around doing those listening sessions formed a planning committee where we had 16 people that worked and or lived on the West Side that helped informed how we built our small business grant program that I'll talk a little bit about, where those dollars went, all informed by community. That then transitioned and fizzed out at maybe about after a year, and we formalized our community advisory council. And so this is our current group of people who represent FQHCs, CBOs, their residents, and they help advise our work to this day. So if you think about our structure, we're not a nonprofit. We are right now a department of Rush University Medical Center. So Rush is our fiscal sponsor. They're incubating us, but we do have a governance structure where we have an executive leadership council where our 6 hospital partners have representatives, and we have 6 community partners that help manage our strategies and visions with my team. So this is just representation of this amazing group from the West Side. And this is the team, the people that make it all happen in partnership with the community advisory group and the partners. So we are a small but mighty team, but in this, again, growing from a team of 1, little old me back in 2018, we were able to expand our footprint to bring in a senior director of program and evaluation, I have 2 directors of anchor mission strategies. And so that's the work where we have our largest investments come from and go back out to community. I do have a video that talks a little bit about our impact. We just turned 5. I like to say we're a kindergartner with adolescent tendencies in terms of our growth trajectory. We have data fellows, we have director of community engagement and that team, and then our ops team. So very proud of the work that we've been able to do in this period. And then our partners. So the engine are the anchors, the hospitals, but also there is a network of folks in terms of our funders. We have the American Medical Association as a mission partner. So they've committed $5 million in our social impact investing work that will go out to investments to help fund affordable housing, other capital developments. We have education partners that help drive the internship pipelines that we're building. And at the onset of COVID, we were part of putting together the City of Chicago's Racial Equity Rapid Response Team that was charged with mitigating a response to the high rates of mortality and morbidity in Black and Brown communities during the onset of COVID. And so that table, the COVID-19 partners, and I know this is small and mighty, but I just wanted to give an illustration of the all hands on deck approach that we take in this space. When we talk about social impact investing as an anchor strategy, we work with community development financing institutions that already have investments that they give across the West Side. We pull together dollars from entities like the AMA, Northern Trust, our hospitals that can put in investment dollars, and we put that back out, where to date, we set a goal to invest 15 million or 20 million by July 31, 2023, and we invested 15. And that's in lieu of a pandemic. Then we have our technical partners. I say all the time that the jet fuel in this work was the ability of us being able to access Bain, Boston Consulting Group, Civic Consulting Alliance, and others on a pro bono basis to really help us stand up and do this work and measure this work. And then we have our economic vitality and healthcare partners. So in terms of our journey, I've prefaced it a little bit just in terms of born out of Rush University Medical Center, setting a table, bringing other systems, bringing in community to work towards our big, hairy, audacious goal. And I'll talk about that shift in the North Star. So I'm going to pause a bit just so you can hear from others beyond me around the impact of our work. And so this is from the voice of one of the founders, Dr. Larry Goodman, Deborah Wesley, Angela Taylor from our communities. And so if technology cooperates, Mercury is out of retrograde if you follow that. So we should not have too much of tech problems.
I'm gonna load it on my end as well in case I need to run it. Actually, do you want to reload it or do you want me to go ahead and try? Ayesha, I think we might be stuck. Do you want me to try on my end?
Sorry, this is why you don't want me doing anything but aside from advancing slides. So
let me see. If you pause for a second, let me see if I can run it on my end for you real quick, because I'd love to hear from others. Hold on one second, okay? So stop sharing and I'll see if I can do it on my end.
Absolutely.
Okay, we're gonna get it on the back end, but why don't you keep going? And we'll circle back to it. You're on mute.
We'll get back there. So sorry about that.
No
But
worries.
talked about the formation. We're five, born out of this vision of Rush University Medical Center to set a table to think about how this region and the economic power of these systems could come together to address this gap. So when you come out of the gate saying that you have this big, hairy, audacious goal, which at the time of our formation was to decrease Chicago's life expectancy gap by 50% by 2030. Wow, massive. We'll talk a little bit more about measurement, but this is the What We Heard report that I referenced that just kind of chronicles the work that was done on the ground to learn from community and to listen around what folks saw as the problem and the solution and how to best activate the work. So talked about this goal. So again, we wanted this to be ambitious, urgent, and something that would motivate our peers to get going. And so this is what we stood by when we thought about how we wanted to approach this work. When we did that, the next step, of course, was measurement and thinking about what were the causes in this gap. And so what we did was we put together a metrics framework team that was comprised of epidemiologists from Rush University Medical Center, the Chicago Department of Public Health. It was chaired by Sinai Urban Health Institute coming out of Sinai, Chicago, and the University of Illinois School of Public Health. And so in this process, it came that cardiometabolic disease, cancer, infant mortality, homicide, and opioid overdose were the leading drivers. And so, as I mentioned earlier, this is a massive list. And for the purposes of us not wanting to boil the ocean but be responsive, we wanted to double down on hypertension management, which cuts across a few of the cardiometabolic conditions, and then the infant mortality rate. And so in the criteria for determining metrics, because the next thing was, all right, we know what the drivers are. How do they compare to the work that we're looking at in terms of our strategies? And so we reviewed existing research with this group to identify the metrics that are linked to the drivers of the racial disparities. And so they're cross-cutting, looking at changeability, looking at impact, repeatability, sensitivity, and understandability. These were our criteria to narrow down the measures, which was a massive list that we got down to about 50. And so talked a little bit about our domains, education. So in order for us to address this gap, to decrease it, we needed to look at and think about strategies that would allow us to impact adult educational attainment, disconnected youth, high school graduation, math and reading proficiencies, kindergarten readiness, terms of economic vitality. And so I mentioned that we had an internship program that focused on not just high school students, but also college students. And so there is some data around the impact of graduation rates, things like that. Economic vitality. So when we talk about our local hiring initiatives to hire local, to create pathways, the idea is that these strategies would align with the eradication of individual poverty, child poverty, impact the median household income by increasing it, providing livable wages, or what we now say is family sustaining wages, and that we address unemployment rates. For neighborhood and built environment, there was a specific focus on food environment, housing, safety and community, and then with health and healthcare, the outcomes around obesity prevalence, psychological distress, behaviors related to fruit, veggie consumption, smoking, teen birth rates, and then health service use. And then the metrics associated with cancer, some of the leading causes. So it's like, wow, okay, we've got it all mapped out here. What we started to do out the gate were the internship programs. We had some initial grants in our inaugural year, looking at healthcare access by funding an expansion of community health worker model in a Latinx community here. We funded co-location of mental and behavioral health services in that first year. We also started to track for the first time our hiring and investments we put together in a shared setting. So this became the heartbeat of the what and the who and the how. And then we fast forward 2 years or a year after building this, and we have COVID come. And after getting data from that first year, we saw one of the sharpest single year decreases in life expectancy on record, with those deepest or some of them being on the West Side in our targeted communities. And so we had to come back to the table to think about what we had put forth in terms of our big, hairy, audacious goal. We had a data retreat with our community partners and others, and we had one of our community residents say, what does it mean to tell my children, my neighbors, that they're only gonna get halfway there? And that was looking at the goal as it was. 50% by 2030, that's ambitious, wow, but I can't tell my children that they have a 50% chance. And so coming into this, we really wanted to rethink the work and how we should position it so that we could be responsive to what we heard, but to push ourselves more. And so that new mission became eliminating the life expectancy gap between Chicago's West Side neighborhoods and downtown. Whoa! So first we're saying 50% by 2030 to now eliminating. And so when you think about our network, and I mentioned some of our partners, it's an all hands on deck approach. We think about education and we think about the work happening in New York and, you know, Harlem's Children's Zone. So it's like, do you need a Harlem Children's Zone in all 10 communities or those that have the higher disparities to address education? As we think about our local hiring strategies and work, where we've been to date over the last 5 years is in tracking the number of people hired. We are now in a position when we talk about eliminating this gap now or eradicating it, where we have to go deeper. Those strategies have to match and have implications and markers around how we're tracking household income and over what period of time, and wages and unemployment rates in community. When we talk about food insecurity and perceptions of food access or affordable access, we are at tables where communities are in protest of grocery stores leaving overnight, but now in a position to help communities plan to bring in other big box retailers. But saying all that to say that we cannot do it alone. And so our announcement of this new mission came in June of this year as we reflected on our impact over the last 5 years. And so another leg of the work is just preparing so that we have the right partners that address each of these. And if they don't, we are building out, this is our mothership of sorts. And we want to have the right folks plugging in to help us think about how we can work together and track together to achieve that North Star. So we've taken out the time-bound nature of the work, and we're aligning ourselves with more partners, more anchors to be more intentional. And so that requires a doubling down in our partnership with the health department, bringing other anchors in. When we think about economic vitality, another project that we have is a laundry linen that we're looking to bring to Chicago to localize the industry, to provide more jobs, to impact unemployment in a community here, North Lawndale, to be more intentional about the wages, median income increases. So the work is really around doubling down more. In the first few years, we had to be up and running. We had to deliver. We had to not overpromise and underdeliver. We had to be intentional around building community trust. And so the work of Westside United is based on the partnership of our healthcare partners and them being active and intentional in this collaborative space, but also us leading with the voice of community and thinking about what other partnerships we can activate to ultimately be responsive to what we have now positioned as our new mission in eliminating the gap. So that's a high level overview. The video just had voice of other community members and some of our other champions to share about. So I'm gonna stop there because I do wanna allow for time before we end to show the video, but most importantly, to hear from you and to answer any questions.
Thank you so much, Ms. Jaco. I'm gonna see if I can play the video. We found it and we're gonna try as folks kind of get their questions together, and we will hopefully be able to go from there.
Rapid response team. So how you bring these resources, this intelligence, this passion to the table to address what's impacting
folks are
not just
hearing.
our communities, but this country, this world. I'm currently proud of our most recent award of the Pritzker Talbert Chicago Prize Award, a new development, a built from the ground up wellness center in our corridor on Madison Street. That's major support. They're not doing it for us, they're doing it with us.
Westside United has brought together funding and resources, grants for small businesses that weren't there anymore, resources and jobs and training for those jobs.
I am delighted to join you today, though virtually, in gratitude for the work Westside United has done for Sweet Home Chicago. I was proud to partner with Westside United to create the Live Healthy Chicago Coalition to serve those in needs throughout the city.
We're celebrating our growth of our healthcare partners in the maternal child health space by partnering to launch Westside Healthy Parents and Babies, providing doula supports and wraparound supports for birthing parents on the West Side. We're celebrating our partnership with the American Medical Association, where we are investing together over $5 million in additional supports, again, all to support the West Side.
The AMA is honored to be part of Westside United. It's really us working together to figure out how are we as AMA, the enterprise really going to work to support the investment in Westside. And I think that it's really inspired us in very positive ways.
As I look ahead to 5
I'm gonna
years, 10
stop
years,
it
I think
there.
there's the real possibility that the city itself
And
I'm just
Westside
trying to
United
stop the video on my end. Give me one. So I think that just that short snippet of the video shows the incredible impact. When I saw Oprah, I almost dropped out of my chair. And I love that there's such a desire for there to be kind of a collective investment. And we have a very obvious agenda as part of this, which is to think of how do other places do this work? And I think one of the things that you shared with us, Ms. Jaco, is the kind of starkness of the problem that when you take the subway from one neighborhood to another, your life expectancy gap drops so precipitously. We know that's the case for us in New York as well. In Brownsville, folks live up to 73. In Midtown Manhattan, that goes up to 83. And those numbers have been that way for a period of time. It's worse now with COVID. It's worse for everyone with COVID, but that gap still exists. And so I would just be curious, to hear your reflections on how we think about this for other places. What are the elements that have to come into place for other places that might be interested in doing this work and taking this on to be able to do it?
Sure. So I would say that you need a starting lineup of influencers. So in our case, you know, having the healthcare anchors come around the table to be on the same page. I'm not saying that it was an easy process or that it happened overnight, but our champion and quarterback was Dr. David Ansel. Um, you know, so I would say you need to identify that person or that group that will be motivated to bring about change. Because me coming as a Black woman from the West Side into this space to talk about it, you know, without that sort of buy-in, meant different things. I could bring partners from community, which has been part of my role in building that trust, but it really had to come from within. So that insulting, if you will, of Rush consulting from within to see how they could be impactful. And so having Dr. Ansel, having Dr. Larry Goodman, then bring their peers around the table was very powerful, as well as having that collective interest as a region and having something, a vehicle that people could see themselves impacting and being a part of. It also took honesty to think about the acknowledgement of these systems who had acknowledged the role of structural racism and historical disinvestment as part of it. So identifying the problem, identifying the champions, identifying the role played in, you know, causing or aiding in the disparity was important. But then the other side of that was being able to listen to the people that was most impacted and giving them agency and a seat at the table to have just as much weight as practitioners was very important because they were genius and experts in their own right. So finding that middle ground was important.
That is really helpful. And I know when we were talking to prep for this session, you know, you immediately said, well, I'm going to come with Dr. Ansel and we'll have this conversation. I was like, you know, no, we would love to just feature kind of your experience, your non-classically, you know, in healthcare and medical voice. And I'm curious how you have experienced that in this work, right? You're sitting alongside the AMA and a lot of folks who are coming from these big institutions. And you mentioned like the importance of your lived experience and you as a Black woman from the West Side being in this. And I'd love if you could share the experience of speaking, you know, on these issues to folks within the healthcare system with your background and what has been challenging about it and what you've kind of used to allow yourself to take up space to really direct the work as you have.
Sure. So I can tell you, coming from the other side of the table, I was very leery, though I loved the work of Dr. Ansel, and it just seemed like a great opportunity to step into to help advise. I was side-eyeing because you see so much of these sort of initiatives that come in, overpromise, underdeliver. They collect the data, the money goes, and people leave. So there was a lot of historic mistrust and trauma just from that type of work. So I was stepping to the other side. And so, you know, some of my colleagues were like, oh, she working for the man, you know, just that whole rhetoric that kind of happens in community space. And so with that, what was so inspiring to see was the intentionality of the systems to listen, to bring their resources to help leverage the genius of community. And so I became part of making this initiative become a trusted intermediary, an honest broker, having the connections in community, being able to make sure we were going into places to help activate what community had already deemed to be their issues, bringing data science, other things that kind of help bridge the gap. But it took me about a year to get there. Just in understanding the process, coming in, feeling comfortable to take up space, right? That was a piece. And so part of that, what drove me was thinking about my grandmother, who in East Garfield Park passed away 2 weeks later after being diagnosed with cancer, ovarian cancer. And it was like, wow, if she had a community health worker at her church where she was hanging out 8 out of 7 days a week, that would have extended her life possibly, to get some early detection and some to go to her visit. Um, and that's what this work produced also in the early days. There was a grant for expansion of community health workers, primarily in Latinx communities for that first round, but it was all about building that bridge, building trust. And it was to fund an organization that had that footprint and street cred, if you will, to build that bridge into this ivory tower of sorts that people didn't feel like was accessible. And so that was beautiful. And being able to just personally arm myself with, you belong here because you have this perspective, was very important. I also had not just David Ansel, but yes, David Ansel, who made space, not just for me, but for other folks in community, like Pastor Marshall Hatch, who we're deep partners with in this $50 million development in the community that has the lowest life expectancy, to co-locate a wellness center there in this corridor. So this is the corridor that has not seen sizable investment since the 1960s, right? We're there to co-locate a federally qualified health center. Rush University Medical Center is putting a center for behavioral health there. We'll have the YMCA co-located there, a cafe, a credit union. So again, it speaks to the point of Westside United. We help set the table, but those anchors help bring in other investments, right? So it was some continuity in the relationships built in 2017 up until now with delivering. And so I've been there to help build that and create that. But I will tell you, it was Dr. Ansel saying, all right, Harvard Business Review wants to connect, you go and talk to them. Just making the space is so important in these spaces as you come with your colleagues that come from community. And so that was a powerful moment for me. So yes, a true ally for sure, a true ally. And the group that he assembled, like just the tribe of these healthcare institutions, and the urgency and the intentionality is something that's still there. And I think community sees that, they feel that, and that's been critical to the success of this initiative.
Mm-hmm. And Dr. Sidursky had asked, and I'll kind of say her question for her. She'd asked, how were residents recruited? Like, who did you select for that initial listening session? And as you answer that, I'll just kind of let people know, feel free to raise your hand or come off mute and ask any questions that may be on your mind.
Sure. So again, having that roadmap of who's who in community, knowing where to go, and some of the hospital community engagement departments had track records and traction, but in our 10 communities, for most of them, the anchors are the churches, the schools. So being able to double down and understand where those places were critical in our recruitment process. We also have quality of life plans here. So if a community has that, they've already assembled a steer code of those anchors that have subcommittees that are working. And so we were fortunate to have access to that. So it's a myriad of different ways. We worked with the champions and the folks on the ground to help build bridges and set those tables and conversations that were sponsored by healthcare or the institution. So we provided food or whatever it was that they needed to set those up to engage with those residents.
And for the kind of participants on the investor side, what does it mean to be an investor? Because we sometimes see, especially post 2020, when there was a lot of kind of like performative investment into racial equity issues, people kind of like throwing money at the issue and hoping for the best. What does it mean to be an investor in the anchor model that you've described? Does it mean that you're kind of, shepherding along the way how the money is used, or is it given to Westside United and they trust that you'll figure it out? But how do you make sure that you have good partners as investors who really see it all the way through?
Sure. So when you come to the table, you've got to affirm that you understand the role of structural racism and historical disinvestment. And in some cases, the role played. So when we think about Chicago and illegal contract buying and all the things that extracted wealth from African American communities, over the last 80 years, that has a historical significance that might tie back to your institution. But most importantly, having that understanding is the first step. The other piece is, in this work, we do not want to reinvent the wheel. We don't want to duplicate services. So when we thought about how to make investments, it was looking around in this ecosystem of who was doing the work. And that was those community development financing institutions that had projects already to help with capital improvement of a daycare center, and they needed capital, or an affordable housing initiative in the far west side that needed funding, or the Cook County Land Bank that was looking to remodel homes so that they could resell them to low-income buyers. So that was an ecosystem that was already there, and we stepped in as healthcare partners. So we also have the Illinois Medical District as an investor, and not all of our partners can invest. Our safety nets cannot. But when we call the investment from Westside United, they get that credit too. So in terms of what it means, we are just in the beginning stages in this work across the country, really thinking about measurement in this space. So beyond dollars, number of dollars invested, this project, this zip code, just what are the implications over time? What does this mean for this community? So we're doing some deep work, also partnering with the HAM, the Healthcare Anchor Network, to think through that. But first is you've got to show up, you've got to be intentional, and you've got to be in it for the long run. So even that first goal of 2030, that didn't mean that we were going to pack up at 2030 and move on. We've got to get to where we are now, which is eradicating the gap. And in some cases, some of the folks around the table won't see that in their lifetime. But the groundwork that we're putting down requires that our institutions dig in and have this be part of their mission and their work in the day-to-day, and that we work alongside the CBOs who have that embedded in their mission, and that we impact the families and communities.
Thank you. And I guess one of the final questions I'll ask is, as we're listening to you, it sounds like you're doing the work of some of the institutions that are present that should be doing this work. And I'll just say it, it sounds like you're almost pulling like a public health function. And I'm just curious, for places that can't galvanize in the way that y'all have, what would you say to trainees and clinicians who are interested in seeing something like this happen? Where could you start this, or where could you look for these kind of investments and just collective organizing to happen?
Sure. So I think there's the power and spirit as I watch a David Ansel, as I watch a Larry Goodman, it's that big thinking. You've got to, within yourself, think big and deep about what the problem is and the solution to that problem, and to surround yourselves with like-minded people. So if that starts with data and you doing some work and research, case studies to identify the problem properly, that's critical. You can work by gaining trust on a small scale. Where do you volunteer? Where do you show up in community? Where do you interact? What do you care most about impacting in your practice, right? So as you identify the problem you want to solve and the big, hairy, audacious goal that scares the shit out of you, for lack of better words, where are the people around you that can help activate that? Is a question, and it starts with you. And I know, if for those of you that are researchers that have, done your practicums of sorts, there is practice for you to do that. But I think it starts with tapping into local CBOs that are embarking in spaces and around things that you care about. So if you want to impact maternal child health or infant mortality, where are those spaces on the ground that are looking to address that, but that need research or some sort of skill set that you can help impact to help show up, build trust, be there, and then open the doors or the windows of possibility in terms of partnerships and other things that you can help impact. So I think it starts with that introspection of what you want to solve, who are the other like-minded people, what is the solution on one track, and as you're doing that to build trust, where can you step in to be impactful now? Community center, CBO, an FQHC, a school, and that's how movements get built.
Amen. It definitely is starting from the small places and kind of building up. I want to just take a quick moment and see if anyone has any words of affirmation for you, because I'm sure this work is not easy and requires a lot of energy to keep going, or any final questions or thoughts that you'd like to share, and then we'll wrap.
This was such an inspiring talk. Thank you so much for your time and sharing your work. Really appreciate it.
Thank you. And I'll just, yeah, please go ahead.
I just also wanted to say thank you for this work and sharing all of this. It's really exciting to hear what was done, and really gives hope for a lot of things that we possibly could do here. I think one of the things that I would love to hear more about, if you have time to say so, is some of the things that really helped you all continue on as you were facing any systemic challenges or things that might have come up.
I think some of the work was done already. Like, I couldn't go into a white power structure or one that has historically been led in that way. And that's a loaded definition, so forgive me. But it took the work of Dr. Ansel and Dr. Goodman to call their peers out and to have the courage. That's also part of this. You got to be brave as hell and have that courage for them to do that. And they were able to do that, but what they couldn't do is reach the people and build the trust. So my lived experience having my folks migrate from the Mississippi Delta to Chicago to find racism under a new guise and everything that came with it helped oil my engine. And we all have that unique something that helps build a bridge somewhere. So I would say that the intentionality of the partners, and then my job to advocate, build the bridge, think outside the box, was part of it. Thinking big and putting it all out there, calling folks out where it needed to be. And then the pandemic was a unifier. It was a unifier, and Stella, you mentioned something earlier. It brought all of these resources all of a sudden. You heard Oprah, if you heard that little snippet, we had Oprah, okay, coming with money for us to help give those resources. And then, a year after George Floyd, of course, there were others, unfortunately, things kind of died down. So I'm thankful to be on a team of folks that are riding it out. And so that's part of it too. Who's your team?
Thank you so much, Ms. Jaco. And I appreciate, we didn't kind of do this as much in your bio, but your original bio talked a lot about your dance background and your music background. And so I want to just call out for folks who are listening that there's all this, as you said, lived experience, but also kind of centering work that you've done that I'm sure keeps you going when you hit up against some of the roadblocks and some of the brick walls. And so for especially our trainees who are listening, who are feeling like medicine wants me to just do medicine and nothing else, I want to encourage you to be holistic, because it can really carry you far in some of the struggles that we have. Dr. Davis, thank you for that question. That was really, I think, a great way for us to head towards wrapping up. And so as usual, Jessica's going to share the links in the feedback links in the chat. Thank you all for being here. We are in part kind of encouraging you. We always have an ask, and I would say the ask is to go ahead and learn more about the work of Westside United. But I want to encourage you to do what was mentioned by someone who spoke up, which was to think about the elements that we could bring here. It's worth us remembering that our institutions are multi-billion, not million, billion-dollar institutions, many of them that are for-profit, that make investments in a very purposeful way. And so as we think about how we as citizens of these universities can direct those investments. I think the example of Westside United and the anchor model in Chicago is one that I hope guides you. Our next rounds will be October 24th. We encourage you to fill out the survey. We encourage you to reach out if there's any speakers, any topics you'd like to have covered. And as always, thank you so much for being here. And I want to just take the last few moments to thank Ms. Jaco so much for her time, for her investment, to thank all the folks in Westside United for building a model that we can follow. Thank you, and this has been great to get to hear from you. Take care, everyone.